So the word cerebral palsy directly translates to brain paralysis. And in this video, we're going to look at the epidemiology, etiologies, as well as the different classifications and clinical features, and so see the diagnostic approach as well as the management of children or who have cerebral palsy. And if you're watching this video and you're not yet subscribed to the channel, please do subscribe so that you don't miss out on any high-yield videos that which I'll be bringing out in the future. So let's get started. This is Midwan Peja and my name is Benjamin. So when we look at cerebral palsy, it's going to be a motor disorder. It's going to be a group of permanent disorders of movement and posture causing activity limitation attributed to non-progressive disturbances in the developing fetal or infant brain. So these injuries occur once during the development, and they do not continue, they are not progress. But because the child is growing, we are going to have evolution of the manifestations of this disease. So when we look at the epidemiology, the global context, the prevalence is about 2 to 3 per 1,000 live births, and this is actually high. Even in the developing and undeveloped countries, the prevalence is almost similar, with even higher prevalences occurring in the developed world. Then we have it's going to be higher in premature infants, that is infants less than 32 weeks, or those with very low birth weight. Then we have improved neonatal survival rates contributing to even the incidence of even more severe phenotypes who would not have survived without the interventions. So the etiology, most of the etiology is going to be prenatal, unlike what most people think that birth asphyxia is the biggest cause of cerebral palsy. Unfortunately, it's not. Most of the time, it is prenatal causes, and these are going to be things like abnormal brain development, intrauterine inflammation, for example, maternal fevers, placental insufficiency, and exposure to methylmercury maternal exposure. These are very, very different things, and they're going to contribute all to the chances of the child being born with cerebral palsy. Then perinatally, hypoxic ischemic encephalopathy coming from things like birth asphyxia is going to contribute, intracranial hemorrhage, as well as severe metabolic derangements. Then postnatally, that is up to 2 years, because after 2 years, we take it that the child's brain has already developed fully, and that accounts for 10% of the causes of cerebral palsy. It's going to be things like CNS infections, traumatic brain injury, severe hyperbilirubinemia, as well as hydrocephalus, and many other things. But that is basically the scheme of events. So prenatal causes are going to predominate, followed by perinatal, and then the postnatal causes. So the key concepts to understand when it comes to cerebral palsy is that brain injury is static, and the manifestations are going to be dynamic. The injury is going to occur, but as the child grows, the manifestations are going to they're going to be showing more and more. And then when we look at motor disorder, it's going to be the primary, and multi-system involvement is the rule, not the exception. So it's going to affect very many other systems. And also cerebral palsy is a diagnosis of phenotype, not of etiology. So when we look at the classifications, we are going to classify them according to the motor involvement or the motor manifestations. And we're going to have the spastic cerebral palsy. This is going to be that increased tone or the spasticity of the muscles. And that is because we have damage to these pyramidal tracts. Sometimes it's called pyramidal cerebral palsy, where we have the pyramidal tracts being affected. And when the pyramidal tracts are affected, you're going to have the velocity dependent hypertonia, which is also called the clasp knife hypertonia or clasp knife rigidity. And this means as you try to move the patient's arm passively very fast, they're going to have this rigidity that after gives way. Then we have the dyskinetic cerebral palsy. This one is also one of the others that are extrapyramidal. It's dyskinetic. It's characterized by dystonia, athetosis, as well as chorioathetosis. So dystonia is going to be altered tone, and then athetosis and chorioathetosis is going to involve the involuntary movement of arms and muscles. Maybe you see the child making snake-like movements with their hands, things like that. Then we have the ataxic cerebral palsy caused by that's going to be manifested by hypotonia and intention tremor, as well as the wide basket. So this ataxic cerebral palsy is going to come from damage to the basal ganglia. The dyskinetic is going to come from damage to the cerebella. Then we have the mixed cerebral palsy, which is going to be a combination of all the above three, and then atonic cerebral palsy, where the child is mostly predominated by tone. And even the children who develop spastic cerebral palsy in the early years, they may first exhibit hypotonia, which then progresses to hypertonia. So it first looks like lower motor neuron, then it goes on to look like then the upper motor neuron. So we have the spastic cerebral palsy, and this one has different phenotypes that are very important for you to know on your examinations. We have the diplegic or the diplegia, which can also be called the diplegic cerebral palsy or diplegic spastic or spastic diplegic, any way you want it. And this is where we have the arms being more spastic or having more rigidity than the legs having more rigidity than the arms. And it's going to occur most especially if a child was born premature. And one of the important features that you see is the paraventricular leukoencephalopathy. And this is because in these premature children, with the blood vessels there's a distribution of blood within the brain that exposes this periventricular area to more ischemia than other areas of the brain. And that is where the pyramidal tracts actually transport the motor innervation to the legs are going to pass. And so when that is affected, we're going to have this. So diplegia is associated with premature as well as periventricular leukoencephalopathy. This is very important for you to remember. Then hemiplegia is going to present like a stroke-like presentation where we have one side of the child being affected. And these children, because one side is affected, they're going to have early hand preference. They're going to literally use the hand that is okay with movement first, and then they are going to tiptoe. They can have circumduction of the limb, whereby instead of lifting the limb up when they are moving, they kind of just move it to the side and then rotate it to put it in front. That's a circumduction gait. And then or the hemiplegic gait. Then you have a limb undergrowth because that limb is not getting very good nerve supply or very good stimulation. Then we have quadriplegia, where we have all limbs affected, and it is the the most severe form of spastic cerebral palsy. And it's going to be associated most of the time with children developing seizures as well as intellectual disability. This is also very important to know about the quadriplegic or the spastic quadriplegia. Then we have monoplegia, where one limb only is affected, and then paraplegia, where the legs only are affected. So when we look at the different brain injury patterns, they're going to give us different manifestations of cerebral palsy. For example, when you have periventricular leukomalacia, we are going to end up with spastic diplegia, which is spasticity of the legs that is more than the arms. When you have parasagittal cortical injury, the parasagittal is going to cause spastic quadriplegia, all four limbs. When we have middle cerebral artery territory infarct, it's going to cause the spastic hemiplegia. Remember, even you're already saying this is middle cerebral artery, so an artery is only affected. It's going to appear like a stroke. So we are blocking one artery, so one side of the brain is going to have issues, spastic hemiplegia. Then when you have issues with the basal ganglia or the thalamus, we are going to get the dyskinetic cerebral palsy, because the basal ganglia is responsible for modulation of motor activity. So we get the dyskinetic. And then when we have cerebellar injury, we shall have ataxic cerebral palsy. So this is a very, very high level for you to understand or to memorize for your examinations. So when you go to the clinical features, we shall begin with the history. And the one of the most important things you will see is the delayed motor milestones. This child is going to take longer to support their trunk, take longer to lift their head, take longer to sit up, take longer to stand if they ever do even move to stand. Then we have abnormal movement patterns, and that is stiffness and floppiness. Even when it comes to other milestones, sometimes they may have delayed speech development, delayed language, because they may be associated with other different concerns. Other brain parts can also be affected. Then we have the non-progressive course. That means most of the time, once they have the spasticity, is not going to improve, or it's not going to do things like ascending. It's going to be like that forever. Then we have prematurity, birth asphyxia, history of neonatal sepsis, poor feeding. Drooling is going to be common, especially, and that is going to cause oromotor. When they have paralysis, what we call the pseudobulbar paralysis, they're going to have paralysis to those nerves that supply the the facial muscles, and they may end up with something like drooling and things like that. Then poor feeding, history, seizures, early hand preference, as well as visual and hearing concerns. Then when you look at the physical examination, they may have abnormal tone, that is increased spasticity, plus or minus early hypotonia. We said they sometimes be hypotonic, then develop hypertonia later on. They have persistent primitive reflexes, and that is important. They may have hyperreflexia, they have Cronus, as well as the positive Babinski sign. And whenever you have positive Babinski, it shows that there is damage to the cerebral cortex or damage to the brain. And whereas this Babinski may not be pathological in younger children, we expect that reflex to go away eventually. So when it stays, it can be a sign that they have damage to the brain. We have abnormal posture or gait, like the scissoring posture, whereby the thighs are kind of like crisscrossing themselves a bit, like a scissor that is closed. And this is going to have issues like when they're changing, the mother is changing a diaper or things like that. We can have toe walking, the spasticity of the muscles of the calf, and this is going to pull the legs up, and then the toes, they'll be walking on their toes. We can have joint contracture to the spasticity. The hands are always held in one place, they develop contractures. We can have limb deformities occurring. Sometimes even due to the spasticity, the muscles can pull on the hip and cause subluxation, or the femur is pulled out of the hip joint, and that causes some issues. You can have limb length or growth asymmetry occurring, and then poor head and track control, again because of the spasticity, the muscles are stiff. Then when you got the diagnostic approach, diagnosis is going to be clinical diagnosis, where we have delayed motor milestones, abnormal tone or posture, as well as a non-progressive cause. And this is very important. Whenever you get a child, you want to rule out the progressive causes that mimic this cerebral palsy, because if you do not and this child just continues, they are going to have that progressive disability, which you would actually have identified earlier on and treated, but misdiagnosed as cerebral palsy. The neuroimaging, the MRI is the gold standard. CT can also help, and it's going to confirm the time of insult, as well as helps with progressification and identifies the malformation. Sometimes you may have a brain tumor, you may have something, this thing like the prenatal encephalopathy, you can only see them on MRI. Then we can also do tests now to exclude other mimics. We can the other mimics like the progressive neurological decline. Again, you know it's not cerebral palsy. If this child is progressing neurologically, you know. Then you have to consider neuromuscular disorders. You have to consider metabolic diseases and genetic syndromes that could also appear as cerebral palsy. So the management principles, the overarching principles is going to be early intervention, family-centered care, as well as functional goal setting and lifelong management. And rehabilitation is going to be a foundation of the management. You want to do physiotherapy for the posture, mobility, contracture, prevention. Then occupational therapy, speech and language therapy, as well as feeding therapy. Then medically, we manage the spasticity a lot of the times, and this is going to include using muscle relaxants. There are central muscle relaxants and the local muscle relaxants. Now, things like baclofen, benzodiazepines are going to act on the central nervous system, they modulate the release of GABA, and then they are going to lead to the muscles being and the muscles relaxing, and this can give some relief. Sometimes it enables the children with actual cerebral palsy to do certain activities that they wouldn't do otherwise with the spasticity. And sometimes even the pain comes from spasticity. Botulinum toxin is one of those local muscle relaxants that are given. Sometimes it's useful to stop the drooling, where they give some botulinum toxin into the parotid gland to stop the release of acetylcholine, which leads to relieving of the drooling and things like that. Then sometimes we use the intrathecal baclofen to reduce on the systemic side effects of the baclofen, and when you use it intrathecally, the efficacy is always good and actually better. So we have to control other things. They may be having seizures and you need to use anti-seizure drugs. Sometimes if they have tremors and things like that, we kind of the basal ganglia features, you can use anti-Parkinson drugs and things like that, like levodopa may help. Then we have surgical management, where we do orthopedic surgery. Sometimes they need tendon lengthening. We can do a selective dorsal rhizotomy it's like separation of those motor nerves that are going to those particular muscles, and this is going to help with spasticity. Then we can do the prognosis and outcomes. Most of the time, we have the predictors of good outcome. That is, if they have a global motor functional CS scale of 1 to 2, absence of epilepsy, and if they have normal cognition. Remember, most of the times in severe cases, they have abnormal cognition or intellectual disability, but normal cognition is going to be a good prognostic factor. Then poor prognostic indicators is going to be quadriplegia, severe epilepsy, as well as feeding dependency. Then we look at the prevention and public health. Antenatal care is important. Infection prevention, maturity prevention, neonatal jaundice control, and therapeutic hypothermia for hypoxic ischemic encephalopathy. So the cause in this is that when you have cerebral palsy, it's not going to be equal to birth asphyxia by default. There are many other things that could have caused it. And cerebral palsy is a non-progressive, but it's not progressive injury to the brain, but it is evolving. And normal early milestones do not exclude cerebral palsy. MRI findings guide prognosis and non-diagnosis, and always exclude progressive disorders. This was made one pager. If you enjoyed this video, please subscribe to the channel if you haven't done that, and leave a like or a comment. Let's meet in the next video.